Assalamualaikum and a very good morning to everyone. First and foremost, I would like to thank the organizer for inviting me to this talk in this conference. The topic that I will discuss is on medical education in COVID-19 pandemic, the Malaysian experience. Before I go on any further, I will recap on what happened during the COVID-19 pandemic, particularly in Malaysia. And you know, COVID-19 is caused by severe acute respiratory syndrome, coronavirus 2, which is transmitted by air droplets. It is highly contagious. Symptoms are mild to moderate, but some patients, especially elderly, are at risk developing severe acute respiratory syndrome and may cause fatality. And ultimately, they have breathing difficulty and organ failure. The SARS-CoV or COVID-19 originate from Wuhan City, China, as pneumonia as unknown origin on the 31st December 2019. Because of the high infectivity, Wuhan population was placed under quarantine or lockdown. And 1 month later, WHO declared outbreak of COVID-19 as a public health emergency of international concern. But this does not stop the rapid surge of new cases of COVID-19 and related deaths, which is outside China and was seen at the beginning of the 2020, March 2020. As to June 8, 2020, there was about 7 million confirmed cases and more than 400,000 deaths were reported from 213 countries and territories. So how about Malaysia? Today, we have 4 to 5 million coronavirus or COVID-19 cases with 36,299 deaths. And the death rate is particularly very high between June and October 2021. And if in terms of Asian, we are the 5th estimated excess mortality rate highest in Asia. So if you actually see the epidemic progression in Malaysia, we were doing very well. But until January 25, there was tourists that come and actually had COVID-19, and at that stage we had our first outbreak, only 22 cases. But then the second wave of outbreak was February 27 onwards, where we have 5,000 to 6,000 cases. And the third wave of outbreak is from October 8, 2020 to the present. So we have around 3 outbreaks at that stage. Due to the outbreaks, to curb the infection pattern of the COVID-19, the Malaysian government introduced Movement Control Order. And this Movement Control Order, or MCO, is a series of national quarantine and sanitize measure to restrict movement, assembly, international travel, and mandate closure of business, industry, government, and educational institution, including ours. The only not affected is actually essential services such as healthcare services. But the healthcare services is actually burdened by the COVID-19. And this also is an aspect that we should look at. The MCO started from 18 March 2020, and then the government relaxed to conditional MCO, where some services such as telecommunication is open, and then it went to recovery MCO, and then went to states MCO by states. However, on 1st June and 28 June 2021, we had a total lockdown, which corresponds to the death that we actually, the death rate, which is higher and higher. And then after having the vaccination, where we start to increase the vaccination rate, then the cases start to come down, and we went into a national recovery plan, which is phase 1 into phase 4. And the MCO ended on the 3rd January 2022, and the last states, which is Sarawak and Kelantan, moved to phase 4, ending the MCO. So in order to prevent the measure of COVID-19, the MOH, or Ministry of Health of Malaysia, introduced guidelines, and they recommended avoidance of pre-C, crowded places, confined places, spaces, and close conversation. Therefore, we actually needed to wear masks. We had to stay at least 1 meter apart from each other, and choose open, well-ventilated spaces over one. So what happened during the pandemic is, for this, we need to understand our curriculum. We have 5 years curriculum in Universiti Kebangsaan Malaysia. The curriculum is similar to other medical curriculum. We have 2 groups, which is 2 years of preclinical and 3 years of clinical. But in our preclinical, there are integrated clinical elements such as skill labs and personal professional advancement. Our medicine and society is also usually face-to-face and with community. So I think the preclinical was mainly and the clinical had psychomotor and affective topics, which actually caused a bit of problem during our adaptation to COVID pandemic, when we discuss later. The initial response that we had is actually do nothing, because we thought it was only 3 months of lockdown, or not lockdowns, is MCO, waiting for the condition to be safe. But at that stage, most of our lecturers had internet, which is only in the office. So they did not have any internet at home. That goes to our students. However, when we had the conditional, the CMCO, conditional MCO, then the lecturer had the luxury to use their internet and do some online classes. So first, we converted all the we stopped all the face-to-face and actually resort to online classes. The transition was smooth, well, kind of smooth for the preclinical, but for the clinical teaching was a bit of a dilemma. Okay. For preclinical, there's mostly lectures, so we had to choose what platform. We had UKM Folio, which is ours, but UKM Folio wasn't matured enough, so we actually resort to Microsoft Teams. However, Zoom is much more user-friendly, but Zoom had security issues. So we had UKM Folio and Microsoft Teams at that time. At the initial part, we had asynchronous. So the students were, all the lectures are pre-recorded, and the students and actually uploaded into the platforms. But then when MCO started to prolong, we started to have synchronous lectures through Microsoft Teams, and that was much more easier. For clinical teaching, lectures are the same as preclinical, but for the clinical lecture, because it's here, we had to use YouTubes. Some companies such as Lecturio and Emboss has to users give us access to give the students for learning for their learning. And then when the condition becomes much more better, we actually had the use of mannequins and simulation. This is when the students are not able to access the hospital because their hospital were burdened with a lot of COVID patients, because we are the center, or hospital was the center of the COVID-19. Okay. So in terms of package-based learning, we in the first semester we had to change it to self-directed learning, but then when we had the internet access, then we use the synchronous platform. For the clinical teaching, when the students had access and were allowed to go into the wards, they are asked to use the PPE or protective equipments for them for their safety. So these are the pictures. If you see, we had here the telecommunication center for teaching, not for clinical teaching, for lectures. And when the students were allowed to actually go into the faculty, they were actually using mannequins. And you can actually see not many students, they had to go into rotation to go into their classes. And after they used the mannequins, we had to sanitize them. So it was 1 hour of using the simulation lab and 1 hour of cleaning. For the assessment method, our usual assessment method is actually divided into two, which is continuous assessment and summative assessment. For the continuous assessment, we had PBL, as I actually told you. We had MCQs, theory, which is MCQ. We also have some clinical inside the continuous assessment, either a long case, a work performance-based assessment, either mini clinical examination, case-based discussion, or direct observation performance jobs, okay, and logbook and supervisor's report. In terms of summative, it is mainly there's theory and also clinical, and the clinical is consists of OSPI and OSCE. And then we have also long case in our summative assessment. So our summative assessment is a combination between theory and also practical. We had to adapt in that sense. It's difficult to adapt the theory, the clinical, because we had to use at that stage patients for our clinical setting, but we have no access to the clinical, so we had to adapt by postponing the clinical exam to the next year, and students were given conditional pass to go to next year. But when the clinical, when the MCO permits us the students to come in, we only use simulated patient and also mannequin. And the last MCO, when we went to the last phase, we can use real patient. We had to do PCR tests on all that's involved. So in that sense, we had to do a lot. The cost of doing an exam elevated so much during that time. Okay. In terms of theory, it was a synchronized online exam. We initially had the open book exam, Then the second, when the MCO2 came into place, then we have the closed book with limited time. So the student has to answer the question inside the UKM folio, the platform. And the last, when everything has settled a bit, during the MCO3, we had the paper-based with online proctoring. That means the students are in the hostel, the invigilator gave the paper-based, and the student had to open their video to see that they are not doing something hanky-panky. Okay. So in that sense, the theory and clinical exam changed, and we had to do mock exams to provide familiarization of the system of those involved. This means our exams and teaching learning method is always changing, and it changes our academic calendar. It's the condition is so dynamic that the academic calendar had to be flexible. And Alhamdulillah, we tried to be on time. The academic policies is mainly on the exam because there are changes in exam dates and format. Our final professional exam is postponed until the end of the year of 2021, and we had to create a new standard operating procedures and guidelines to cater for the changes. So these are some of the guidelines we had to comply. We had SOPs from our main campus, but we also have our own faculty SOPs, because medical education is only in the in our faculty. We also had changes in terms of SOPs for students in our hospital. Okay. In the exam, if you actually see, we had a big SOPs guidelines for synchronous, non-synchronous, and paper-based exam. So currently, we are endemic phase. So what next, actually? Well, the online classes had boomed during the pandemic, and we realized that it will never replace the face-to-face and hands-on approach. So these are temporary methods during the pandemic. Now, currently, we are easing back to face-to-face. The only adaptation, not the only, we actually currently realize there's a lot of things that can be done online. We are probably going to do a hybrid session online and also face-to-face procedures, face-to-face session only if the condition are required. So our adaptation to COVID-19 will not be successful without the help of everyone involved. I acknowledge the previous Deputy Dean, Prof. Roslina, for being there during the COVID-19 pandemic. With the help of the Prof. Roslina is here, and we have the help of medical education, Dr. Norman and his team. This is not Dr. Nasri for the assessment method, and this is the clinical, and we had a lot of help from the head of modules and coordinators, and this is Dr. Norman as I discussed, and these teams actually, the whole team actually contribute to the success of the teaching learning method and exam during the COVID-19 pandemic. With that, I thank you for your attention.